Hi, my name is Dr. Raja Adnan Ahmed, and I'm a psychiatrist and I work in UK. And with me this morning is Dr. Shawn, who's a core surgical trainee and he is working in England. And this video is part of my series where I'm talking about how to cope with the first jobs. So I've already done a video on how to cope with the first job in medicine as a junior doctor, how to cope with the job in pediatrics, and how to cope with a job in emergency medicine, A&E as well. So this is specifically for surgery because Shawn has got a very good experience as a junior doctor in surgery. So I invited him to share his experience and advice to the new IMG when they are starting their first job in surgery. And we will talk about general surgery and also orthopedics as well, which is another branch of surgery. So Shawn, first of all, thank you very much for joining and giving me the time.
Good morning, sir. I think I'm glad to be here, sharing my experience about surgery. I know how it feels when you start a new job in a new specialty in a different country, different system, and how cold feet we can get sometimes, all the anxiety. So I'm happy to share my experience and if it helps people starting their first job.
Thank you very much. So obviously, just to say to the audience that, obviously when you're starting a job, it will be in a different department, the consultants will be different, the structure would be different. So we are sharing here very general advice, which could be used for anywhere, but it's
Yeah.
not like that it will be applicable to absolutely everywhere. So Shawn, let's talk about the general surgery first. When a junior doctor gets a job, as an SHO, a non-training grade in a general surgery, what is the expectation, from the hospital or for the senior on the ward? What sort of jobs they are supposed to do?
So I think I can, divide them into few different categories so that it's easier to understand. So the first category would be the ward jobs. So the basic expectation of the ward jobs is, to divide into three different orders, which is like prepping for the ward round is what you are expected to do. If there is any investigations, you need to know about the investigations that was done. If there was any scans that was done, you need to know about the scans results that was done. If there is something about the concerns, you have to make sure that is noted down into the ward round that you are preparing. Now, second comes the job list. As you go around the ward round, the job list needs to be updated. It can be according to your style, whatever suits you the best, but the job list needs to be updated. Then the next steps comes in completing of the jobs. Safety always comes first in completing of the jobs. So the people who are sick, the people or in the ward round, if the consultants would have told you something which is important, those things needs to take the top priority. And in that order, you go down and finish your jobs along with your colleagues. So that is something which is expected, very basic expectations during the ward round.
And your job list, you use the term job list, which is I think important. This is basically if you're going on a ward round with a senior and they give you some jobs and do bloods for this person, do this
Yeah.
ask for this investigation, refer this patient to medicine or something like that.
Yeah.
So that job list can be created from your ward round and also sometimes from the nursing staff as well, because if they are noticing any concerns, they can
Yeah.
also approach you.
So I think especially in surgery, depending upon different hospitals, of course, but in generalized version, your job list starts right from when there is a morning meeting. So every day before we start the ward round, there is a morning meeting where all the scans and all the patients who were admitted previous night or the previous day is being reflected upon and all their scans have been seen. So the job list starts right from then onwards. Because if the consultants are making some plan and you know that today is your day to go for the ward round, you need to keep noting them down right from the start. And then as of course you go around with your senior colleague or the registrars or the consultants, they will keep telling you for this patient, you have to prepare discharge summary. For this patient, you have to order bloods, make sure the bloods are ordered. The scans are to be chased. Please make sure you do a dietitian referral. You make sure you do a stoma nurse referral and so on. So those jobs needs to be noted down. And additionally, of course, when you are done with all of those jobs, then the nurses definitely add on to those jobs because they, being at the ground level, they know a little bit more about the patients and what they need. So those jobs needs to be added into your list and to be done. The most important thing about the job list is to prioritizing the job list and not according to the order you went for the ward round is something that is expected from a junior doctor.
So by prioritizing, you mean obviously that if there are more urgent things that needs to be done first, something can be done later on, and sometimes they can be done the next day. So you need to
Next
have
day.
that understanding, prioritization that which one is urgent. So this was about the ward round and how your day will start normally on the ward. Is there anything? else as a SHO you do that?
Oh, yeah. So this was about the day jobs. Then comes the on-call duties. Now, on-call duties, we know roughly ranges from 12 and a half hours to 13 hours, depending on which specialty you are working. So the basic on-call job is to basically support your registrar. That's the basic understanding of the on-call job. In that particular way, generally, general surgery works in two different ways. One, that you will also have to be in the assessment unit, which means patients who are coming in fresh from A&E, you need to see them. That means you will have to do basic stuffs. So what is your expectations from your senior colleague is you should be able to clock a patient. That means take a good history. You should be able to do a good examination, physical examination, and you should be able to form a differential diagnosis, if not a definitive one. Of course, it's difficult. And at least you should start the initial management plan. If you are confused or if you have any doubts, you should make sure to speak to the registrar right away, because registrars prefer knowing about patients than not knowing about patients till the handover is going on in the evening. So every people work in a very different way. Some consultants and some registrars would tell you very beginning in the beginning of the rotation that I would rather know about the patient than not know about the patient till the handover is being done. So if you're confused about anything, if you have any doubt, it can be a silly doubt, but it's always good to run by the registrar who is available on that day. Apart from on-calls, you would also be asked to support in the theaters. Now, theaters is something which runs very differently back home and in the UK. It will take some time to adjust to the theater's understanding. The basic understanding which everybody wants is that you should know how to don and glove, how to scrub. That's the basic important thing. And something which I have seen that lacks a little bit when you initially start is introducing yourself to the entire theater team. That is so important in the UK because people would want to know who you are so that they can address you and they can know that what level you are so that they are not having a higher expectations from you in the theater. And in that way, I feel when you go and introduce yourself, taking the initiative, people like it. People love it when you do that, and that makes sure that you are a junior doctor and you're taking an effort to introduce yourself, get to know the entire theater team. That makes it easy during the surgery quite a lot. So that is something which I would advise you to always do. In the theaters, of course, they would not expect you to know every procedure that is being going on. Basic things they might ask you, and if you are not confident, you should be able to tell, no, I do not know, or I'm not confident. I think truth is something which is very much expected. You don't have to showcase yourself that you know everything. If you are doubtful, you should say that I'm not very confident in doing that, but I know how to do that. If you assist me, that would be more than helpful for me. So I think being upright, knowing your limitations is something which is very much expected in theater, because in theaters, a lot of things can go wrong and we wouldn't want that for the patients.
I think you touched upon a very important point is about introducing yourself. And I always advise the junior doctors, not just for theaters, but even when they're going on the ward, because the ward team might know each other and they've been working with each other for a very long time. Same with the theater. And if there's a new face, and that face is not introducing and just having a badge and expecting the people to read the badge and know who they are, it's much better to introduce yourself and tell who you are and how long are you going to be there, what is your. Then it basically breaks the ice, definitely. Another thing you mentioned was is important. I think in our IMT group, a few people have posted about that how do you scrub is something maybe in the developing countries, people are not taught that well. And when they're going for the theater for the first time, have you seen people struggling or you can tell us, how do they actually learn how to properly scrub prior to going to theater? Is it sort of part of lab, or is it something that you are taught anyway in the surgical rotation, or is there something they can watch a video online or?
So I believe it was a part of PLAB syllabus maybe in 2015-16 when the syllabus changed, when it was very less number of stations at that amount of time, where they had suturing and gloving and everything at that moment of time. I think now they do not include all these things, at least not when I gave my PLAB examination. Scrubbing is something which, of course, you can learn by looking at the YouTube videos. One thing which is important during scrubbing or after scrubbing is understanding the difference between a sterile field and a non-sterile field. I've seen a lot of people who have entered or who have come for the first time or second time to the theater, not having that awareness makes, it's not like they are at fault. It's just that that's what is expected in the theaters, that you understand what is the difference between a sterile field and a non-sterile field. So it has happened few times that somebody tends to touch a non-sterile field and is asked to de-scrub and scrub back again. Or we'll have to change the entire preparation for the patient. We have to throw few things, bring in new stuffs. So those are something which needs to be kept in mind, because nobody wants to delay the surgery, because those things delay the surgery. And we would not want the patient to be under the anesthesia for a long period of time because of those small delays. So that is something which is expected. However, regarding scrubbing, we can always learn by looking at the YouTube videos and knowing what is sterile, how to open the gown packet, and how to make sure that it is still sterile when you are gloving yourself.
And what is your expectation as at a theater table? It's just to clarify, as far as I understand, it's the surgery is led by the middle grade or the consultant. So as a junior doctor, you're not expected to actually do the surgery as like an SHO grade doctor. So what is your expectation there? Is it all about how much skills do you have, and it's all about what sort of procedure is going on?
So I think expectations are different at a different level of grade. So if you are an F2, your expectations would be just to assist in the surgery and to probably close the skin. If you are confident, they will ask you that, have you closed the skin before? And if you say you're confident in closing the skin, or you say that I'm half confident, but if you supervise me, I will learn. That is also okay, but you should be able to tell that. If you are at an SHO level and you are doing as a CT rota, which means a co-trainee rota, which means the expectations is a bit higher, so that they will be expected that you should be able to close the layers of the skin till they write the OT notes or the preparation notes, so that it takes less time because you have distributed the job and the patient can be out of the theater. So the turnover of the theaters is well maintained. So if you're not confident, you can say you're not confident, but if you're confident, they will at least expect you to close the skin. And that thing, I think, will come slowly, because once you have entered new into the team, the registrars will take a little bit of time to get accustomed to you. You will take a little bit of time to get accustomed to their methods of working in the theaters, and they will know your competency by then. And they'll be like, okay, are you happy to close? Okay, I'm going to write the OT notes. So if you're happy to close, you close the skin, you close the layers of the abdomen, or you close layers of the skin, and finally you close the skin, make sure everything is dried up and everything, all those things. So in the initial few phases, you can learn by looking at it, how it's done, and then you can of course take it up. But if you are at a core trainee level, things changes a little bit slightly. So the first day I went into general surgery and I was on call on my first day, they asked me that, have you ever done an abscess? Because there was an abscess in the theaters and they all expected me to get the abscess done. And I had done abscess. So it was during the morning meeting, and the consultant asked me, are you happy to get crack on with the abscess so that we can continue with other cases in the other theaters? I was like, fine, I can do the abscess because I've done so many abscesses. He was like, don't worry, one of the registrars will be around just in case if you get stuck, you can always ask for help. I was like, thank you, that would be really helpful. So that's the expectations on day one of me joining general surgery. If I was not confident, I would have told that this is my first general surgery job and I have not done abscess ever, but I'm happy to learn in the few instances and just assist. And probably from next time, I can start doing the abscesses. So I think the expectations at different levels are a little bit different. And I think that is something which we should be always keep in mind when we start the job.
And there's another thing to clarify about on calls. You mentioned that people have to see the patient and clog the patient. So my understanding that the patients are, by the time they're coming to surgery, they have already been assessed by A&E or a GP. So there is some history already available. There are some concerns already highlighted. So when you're taking history, you usually have some degree of history already available and some degree of investigation already available. Is that correct?
For some patients, yes. For some patients who have been referred by the GP, that is correct. You will have a letter from the GP, ideally, or just at least a small, letter from the GP saying, this is a presenting complaint. I've assessed the patients and I'm expecting so and so diagnosis. And please, can you, do the further investigations and stuff like that. So that is one way of how the patients come in. The second way the patients come in into the hospital is they come to A&E. Once they know that it's a general surgery issues, they are not seen by the A&E team and sent specifically directly to the surgical assessment unit, SAU unit. That is very specific to general surgery. So you will get all new, fresh patients with no prior history or no understanding of why they have come unless you start taking the history. The other kind of patients which come, at least in my hospital, is from a bed bureau. So if there is some patients who we already know, they are somewhere at home or in the residential home or care home, and we know that they are very poorly, and they straight away call to the bed bureau saying this patient cannot travel themselves to the hospital and they would need a bed straight away. So they come straight to the bed. They don't come to SAU. They don't go to emergency, but they straight away come to a bed in the ward. And then you will have to go and see the patient in the ward. That's another kind of patients. And the fourth kind of patients that definitely come is they came with some issues. A&E has assessed them. And now they've figured out, okay, there is a bowel perforation or there is an issue with the general surgery problem. Then they will refer the patients to the general surgery department.
What about the patients who have planned surgeries, elective patients? Are they also being admitted for overnight, or they're coming directly to the day surgery?
So in some hospitals, the elective patients, when they come, they usually are having a clocking booklet beforehand because they were seen in the clinics and clogged beforehand. So what you need to do is to make sure that they have got the up-to-date bloods in the night so that they are okay to go for theaters the next day in the morning. The other kind of people can work is that elective surgeries are done in another hospital, which means the patients come as a day case surgery, they get things done, and there is all different sort of doctors who look after them. The other kind of is sometimes when there is problems with the theaters list, or there is a problem with putting the patients into the correct theater list. Sometimes elective patients also come into the emergency point where they come over the night. So that means you will have to clog the patients, make sure they again have the scans which is requested up to date. You have to go through the letters of the consultants to see if there was any pending investigations that needed to be done when they come to the hospital. They need to get the swabs done, MRSA swabs done, get up-to-date bloods done, and making sure if that procedure requires group and save or cross-match, that is available in the morning so that they can go to the theater straight away.
And you covered the inpatient work and the theater work and on-call. What about the outpatients? Because there are clinics going on as well. As a junior doctor, do you expect to, because when I did my surgical rotation as my FY2, I wasn't doing that much outpatient because that was led by mostly the registrars and the consultants. We could go and observe them, but we're not given our own patients. I'm not sure if this is like a standard all over UK, or was it just that particular hospital doing that?
As far as I am aware, at least for general surgery, an F1 is never scheduled to be in the clinics. But an FY2 in my hospitals, all the FY2s at some point of their stage are scheduled to be in the clinics, but they are very, on the observation side. So they just observe how the clinics runs, how the follow-up patients are being consulted by the patients, and how the communication is between the patient and the consultant. But sometimes that's a good place and an opportunity to have a case-based discussion between two patients. You can ask the consultant that can I have a case-based discussion on this patient, or do you mind if I just take a quick history for this patient and do a quick examination to do a mini CACs done. So it's a good opportunity whenever you get the time to get the case-based discussion and mini CACs done. Of course, each consultant is different. They might not have time between two patients. That's why sometimes it's good to have to build a rapport initially with the consultant or the registrar and get things done in the clinics.
There's another aspect, I think, for the surgery, specific for surgery, but some medical specialty as well, about this. When a procedure has to be done, there are, as you said, there were some investigations, some things done earlier. But what about explaining the procedure to the patient and getting them to sign the form? Is that something that the junior get involved in as well?
Yes, again, everything depends on what level you are working and have you done that before or not. Because every time a registrar or a consultant asks you to do something, some consultant would just expect you that you know it, and they would not ask you that, have you done this before? But if you have not done it before, you have to make sure that you tell to the consultant right away that I've not done it before. You don't want to be in deep waters just in order to make sure that you come into the good books of the consultant, because if anything goes wrong, then you are in the bad books definitely. So most important point is that if you are an F1, you're not expected to consent a patient or explain regarding the procedures. If you are an F2 and if you have done that thing before in different specialty, then you can tell that, yes, I'm okay to consent for simple procedures like abscess, appendix, and stuff like that. For bigger procedures, they would never expect an F2 to get done. As a core trainee, they'll expect you to able to consent, know the procedures, and be able to communicate that and get the consent done for the patient. So that's an expectation at a core trainee level.
I think we will next move to the orthopedic, but I just wanted to one more question about this. If a person, and I think it's very relevant for IMGs, if they started a job in surgery and they are looking to become a surgeon, core training level, I mean, there will be some people who will not be interested in surgery and they say, well, actually, this is my stepping stone. I want to become a GP or psychiatry or medicine after this. But people who are actually interested in surgery and like to take this as a career, what sort of opportunities they can explore within that SHO job, which will look good on the CV. There are some basic things like ability to teach, do some audits, research, but anything else in terms of specifically surgical procedure and all that they can get signed off
Oh,
or
yes.
do.
So in terms of the surgical specialty and core surgical training or even higher specialty training like ST3, the basic few things which remains constant is that you should be able to do basic procedures. That means you should be able to open and close the skin. That is something that you can get signed off. For as a core trainee, we are required to get signed off for downing, gloving, scrubbing, preparing the patient, cleaning the patient, and making sure that the patient is ready to start the surgery. So all those things gets into account. So you can get signed off for all those things. The other things that you can get signed off is for your lap appendix, because that's the basic things which is required for your ST3 level. If you are too junior, they might not let you do the procedure, but how you can start off the procedure is you can start off that, can you please help me or get the port inside? So you start off by inserting the port, you start off by taking out the port, you start off by doing few bits and pieces of the surgery, and then you ask them, the other registrar, that, okay, I've done all of these in small instance, would you be happy for me to do a couple of things together, or would you be happy for me to observe when I do the procedures at least half of it? So those are something which you can get signed off. The other things which you can get signed off is incision and closure, which is very important from a core surgical point of view. Apart from all of these things, which is important for when you are applying for core surgical training, is getting your teachings and audits. In general surgery department, I think audits are running every month. You just have to get your name into it and ask a consultant that, if are you happy for me to lead this particular audit? And I'll tell you more, most of the consultants are very happy to let you lead in the supervision of a registrar or in the supervision of themselves as the consultant. So audit is something which is required, which is important. It gives you one of the highest points. The other things that people, if they have not done prior to coming or joining in the UK, that what they can do is to pick out a case history, which is important, or they have seen, or during the discussion, they have noted that the consultants have told that this is something out of the ordinary, you don't really see in, on regular basis. Pick those points and make sure you make a case history out of it and present it in the national or international conference to make sure that you again get some more points.
That's good. Thank you for sharing that. So this is the last part of the interview about orthopedics. Is there anything specific which is I mean a lot of what you talk about, doing the ward job, the theater and all that will cover in orthopedics as well. But as a specialty, orthopedics have they got something special which is on top of what you need to know from general surgery?
Especially in orthopedics, they would not expect you to know most of the things in the theaters because their theaters runs very different. Their scrubbing also sometimes is different in different hospitals. I've seen in different hospitals where they scrub 3 times rather than just 2 times, because of course, because of the concerns about the metal work getting infected, and we wouldn't want that in the patient. That's why sometimes we have to wear 3 gloves rather than 2 gloves, because we know that we are going to change gloves in between the procedures multiple times. So things works differently in different hospitals, but at least 2 times gloving, which is something which is important in theaters perspective. I think the other thing which is required and important from an on-call perspective is to make sure that you know neck of femur fracture. because that's the basic thing which all the registrars would ask you to see for sure. As you're starting the on-call, they'll be like, okay, can you go and see this neck of femur fracture? And I'm going to see this patient. Some hospitals, because I was working in London in orthopedics as well, they expected you to know all the neurological examinations so that you can basically assess cauda equina syndrome, because that's a medical emergency, surgical emergency. So you should be able to know how to assess cauda equina syndrome. And then, of course, making sure that you are escalating it if there is any finding at all. That is something orthopedics is different in that regards. And the third thing I think, which I will tell you on during the on-call, would be casting and manipulation of fractures. Not a lot of A&E people do that these days. So in my hospital currently, A&E people hardly do the manipulation. So which means that all the manipulations are either done by the on-call team or by the specialist nurses. So for basic stuffs, if you are on call, they might ask you to go and manipulate. But again, if you have never done manipulation in your life, you can always tell them that I can assist you now, learn about it, and then I can start doing it from the next time. But that is something which is expected, because the registrars can't be everywhere. So as an SHO on call, they would expect you to know basic manipulation to be done.
And as a simple rule, like if you have seen a patient, like it's a very simple question from as a student, I can ask you, if you've seen a patient in A&E who has broken a bone and you're not sure if this is something that needs to be admitted or needs casting, can they go to fracture clinic? Uh, what sort of thing you do? Actually call the registrar and send them the scan, or do they come and see the patient? What normally happens around that?
There are many different ways to approach this, honestly. If I have the time and if I am not very confident, I would just open up Ortho Bullets, which is the primary basic area where we can turn to if we need any kinds of fracture or any kind of advice that we don't know about a fracture. If I have the time, I'll turn to Ortho Bullets. That's what I did initially when I started the ortho job. Some people have the textbooks in their hand, where they look about the fractures and how it's going to be managed. Some people have different apps. I personally use Ortho Bullets. I think everybody will recommend to use Ortho Bullets. Sometimes when they know that you are very new to the job, so the registrars will make it a point to come and see the patient themselves, because they know that you are new to the job. So they want to support you in making a decision and also make you learn how a decision is being made regarding such kind of fractures. So you should definitely tell to the registrar that you don't know what are the next steps going to be, and they'll make a point to come and see the patient and discuss the management plan with you and also make you learn how management plans are done. The basic things are, over the night, if I as an SHO, if I've seen some fractures, for example, a distal radius fracture in an elderly patient who fell, I know I have tried manipulating it. If it is not right in its place, I know that it is still displaced and I was unable to manipulate it in the good way, then it is no point in keeping the elderly in the hospital rather than sending them home and bringing them early in the morning into the fracture clinic where they can redo that with the registrar. But you should be able to try to manipulate at least in the first attempt and see if it gets into position or not. That is expected. Sometimes if you don't know anything, speak to the registrar, because most of the registrars are very welcoming. They will want you to, as I said before, they would want to know about the patient rather than not know about the patients till the morning handover comes up.
So as part of on-calls, I think I just wanted to ask you two things. First thing is, like a medical on-call doctor has a bleep, which is recess bleep as well. So if a recess happens, they run to that. But I've seen in surgical SHOs, when I was in orthopedic as well, we used to have our registrar and we used to have something called a trauma bleep.
Yeah.
That if there's a trauma that comes to A&E, then
Yeah.
we used to run to that as well. Is that something that the orthopedic or the general surgery SHO is expected to do as well?
So different hospitals runs in different way. Definitely the trauma bleep is with the registrars in general surgery in some hospitals, and in some hospitals it's with the SHO as well. Usually the general surgery registrar will definitely come with an SHO most of the times to assess a trauma patients. And as an SHO in orthopedics, you would be holding a trauma bleep most of the times. So you would be expected to go. Different hospitals again works in different way according to the arrangement between the different specialities. In London, the general surgery team was supposed to do the basic primary survey, A to E management, and an orthopedics team was supposed to do the secondary survey on the patient. In this hospital, A&E does the primary survey and the orthopedics teams does the secondary survey, and general surgery teams only comes into account if there is an input required from general surgery team. However, you need to be present there, but usually the general surgery team is not doing much in this hospital until unless there is a shortage of people around and somebody who has not come and you need to assess the patient quickly, then of course the people, all hands on deck system works. But different hospital works in different way, but you will carry a trauma, which means you need to almost leave everything until unless you are with a very sick patient. You need to reach wherever you are, where the trauma is, especially in A&E, most of the time in A&E settings, you have to reach to the A&E because you will have to sign your name and the time you have reached. So those all things are taken into account. And sometimes if you are too late or if you fail to inform the trauma leader that you are busy with an unwell patient, that gets flagged up to your consultant.
Thank you for sharing that as well. I think there was one aspect which I think I was even missing about. There must be emergency theaters going on as well, because you said as an on-call, you are expected to see
Yep.
patients and sick patient, admit them or send them home or whatever. But there must be patients who are very, very unwell or broken a particular bone, open fracture, which needs immediate surgery. Or same with the general surgery as well. There must be patients who are requiring emergency surgeries as well. So are you, as an SHO, getting involved in that, or is that something a registrar or consultant are doing and you covering the grounds and the wards when that is happening?
So in orthopedics, you do not really get involved in any emergency, because if you get involved in the emergency surgery, then there is nobody to look after the on-call patients who are being referred. So it's usually the registrars and the consultants who go and get the emergency done. But in general surgery, things are different. If it's over the night, then you definitely get involved because there is nobody. You have to start off the surgery with the registrar initially. And if the consultant comes in, and if the on-call is not too busy, you can continue to stay in theaters. But if the on-call is busy and the consultant has reached the hospital, then you need to go off to keep doing your on-call and seeing the new patients that are being referred. During the daytime in general surgery, it works again different in different hospitals. Some hospitals, you would be required to be in the theaters because as a on-call team, you're supposed to be in the theater. And in some hospitals, the registrars, again, because there are enough number of consultants available during the day, there are enough hands to be done in theaters. So it is advised that you be seeing the on-call patients and the new patients, and when the registrars comes, you can discuss all the patients with them.
So it will be a lot about the way service is set up as well. That's
a lot.
I think the last question is, I mean, you mentioned about the fracture clinic, and I think at least when I was in Pakistan, we were already doing these fracture clinics there as well. The fracture clinics were basically the outpatient clinics for orthopedic were called fracture clinics. So what is actually the fracture clinic in UK? Is it the same is it like a routine outpatient? Is it a special clinic for people who have active fractures? What is the concept of that?
I mean, it's again very different in different hospitals. In London, where I was working, their fracture clinic means outpatient clinic who are coming as a follow-up. And if any casts required splitting or any cast requires redoing, or if the cast requires coming from a back slab to a complete total cast, that things can be done in the fracture clinic. But it's mostly the patients who are coming as a follow-up patients. However, currently where I'm working and I'm having done orthopedics here, there are two different kinds of fracture clinic. One is for an follow-up fracture clinic, and another is for an active fracture clinic where patients can be brought in for manipulation if the manipulation is unsatisfactory. Patients seen in ED, manipulation done, but manipulation is not in the right place, can be brought into the second fracture clinic where active manipulations are getting done by specialist nurses and the on-call registrars and SHOs of the day, and making sure that the position is good enough or satisfactory before they are sent home. As an F2, you are not expected to be in the fracture clinic, but of course you can request some time in the fracture clinic to see how follow-up is going on. But as a core trainee, you are expected to run the fracture clinic. You will have your own patients, but you can, if you have any doubt, you can always communicate with the registrars or the consultants next door regarding the further management plan.
So thank you very much for your time and giving us all this information. I think this was very useful, especially for somebody international medical graduate who's coming to the UK for the first time and starting their first job in surgery. So I'd like to thank you again for giving the time.
Oh, no, sir. Thank you so much for having me. Actually, I think it is good that we talk about these things so that people are made aware before they start their first job. The only tip that I would give people who start their job as a surgery is surgery's ward round differs massively from the medical ward round. So what you need to do is because the surgery ward rounds are very fast, you might not get the time to even write everything in the notes, but taking down the job list is the most important task that you can do on that day. Okay, so because the surgery ward rounds are very fast, it gets over within an hour or so, looking after 30, 35, 60 patients sometimes. And medical ward rounds might take up to 3 hours, 4 hours, going through every scans, every blood results, teaching during the procedures and stuff like that. In surgery, you will often feel that you are not being taught during the ward round. That is because of the fast nature of the specialty. But don't worry, at some point or the other point, you will definitely be taught whatever is required for you to, especially during the on-calls with your registrars, in the theaters with your registrars, in the clinics with your registrars, you will be taught many different things. But the ward round is something that is very fast-paced, so make sure to keep up as it is.
Oh, thank you. Thank you very much.
No, thank you, sir.